Today's episode of the Juicebox Podcast is sponsored by Dexcom. Did you know that the Dexcom G5 mobile CGM system is the first and only CGM platform available on Android in the United States? It's also available on iPhone, and it comes with a nifty little receiver. Go to dexcom.com/juicebox to learn more. Flexible, precise, simple, discreet, waterproof. That's what the Omnipod tubeless insulin pump will bring to your life. Today's episode is also sponsored by Omnipod, and if you'd like to learn more, please go to myomnipod.com/juicebox. And now, on to the show. Hello and welcome to episode 140 of the Juicebox Podcast. You're going to remember that back in episode 137, we spoke with a physician who was diagnosed while in medical school and has had type 1 diabetes for a few years. Now today we're going to talk to Dr. Eric Johnson, who was diagnosed at a similar time in his life, but 27 years ago. You're getting a little ghosted diabetes present and a little ghosted diabetes future through the eyes of physicians. Listen, don't forget, nothing you hear on the Juicebox Podcast should be considered advice, medical or otherwise. Always consult a physician before being bold with insulin. Speaking of being bold with insulin, if you want bold with insulin t-shirts before the holiday, you should order now. Go to juiceboxpodcast.com for that. At the very end of this episode, there'll be a tiny little tease about next week's guest. I think you guys are going to love it.
My name is Dr. Eric L. Johnson. I'm a physician in Grand Forks, North Dakota, where I am employed as an associate professor at the School of Medicine and Health Sciences here at the University of North Dakota. And I'm the assistant medical director for the Diabetes Center at All True Health System, also here in Grand Forks. And I've had type 1 diabetes for 27 years.
Wow, that's, how old are you, do you mind saying?
56.
56. Okay, so you were diagnosed in your 20s then?
I was an adult. I was a couple months out of medical school. Of course, we know a great majority of type 1 cases are before age 25, but there is a small percentage that are later. I have diagnosed people in their 40s or 50s with type 1, so it does happen.
Yeah, I've actually interviewed somebody that was diagnosed just prior to their 60th birthday.
Oh my!
Yeah. So it really is strange. So I'm interested to know that when you've got an MD when this happens to you. You had just gotten it.
Yes.
Is it better to understand or not understand, do you think, when somebody tells you that you're sick?
That was really a mixed experience. I had a very good idea of what was wrong with me, and I was doing my residency in Fargo at that time. And I had moved from Omaha in May, and this was in July. Mm-hmm. And I'd actually gone down to Minneapolis for a couple days for some baseball. And on the way home, I felt really poorly. And a couple days later, when I got back to clinic, I was really quite ill. And I had all the classic signs. I had the knowledge, but I was really more upset by the timing of it than anything else.
Just because it felt like your life was getting ready to get going, and then this.
Yeah.
Yeah.
I guess that's exactly right.
Right, because you fight your way through high school as a child, you make your way into school, medical school, and you just think, okay, I've given the last easily decade to serious study, and now I'm going to start my life. And then did it hold you back in any way? Did it impede your practicing?
I took about a week off. The University of North Dakota, where I did my residency, they treated me great. Our program directors and my fellow residents were extremely supportive. And of course, back then, we didn't have great quality insulins or technologies. This would have been 1989. And I got started on NPH and regular twice a day, bottles and syringes. Yeah. And I had a glucose meter, but it was of the technology where you would put a drop on the stick, you would have to wipe it off a minute later, and then put it into the meter, where it would take another minute to read, and that was assuming that you didn't get an error message.
Right.
And a meter was not something that you would carry around with you. Yeah, that stayed at home.
It was that sort of block thing, like the size of a brick, about the size of a brick, right? That's what they
Yeah, that's pretty close.
Because I graduated from high school in 89, and a friend of mine was diagnosed our senior year of high school, and I remember him getting this big, I remember it being this big tan thing that just sat in his house, you know?
Yeah, and some of the newer meters were emerging at that time, but their quality wasn't that great. Mm-hmm. I had that one that was about the size of a cigar that I was trying out for a company shortly after this. And it was not a great device, so I didn't really come to rely on it. But it was, the quality of the treatments it was kind of just before the golden age of where we started seeing better quality insulins and better quality technology.
What was the goal? What was the goal given to you then because I'm assuming you saw an endocrinologist, and so what was the goal? What was living a healthy day? Like, what was the bar set at for you at that point?
Since you were on insulin products like NPH that had about an 8-hour duration of action or so, and peaked at 4 hours, the meal schedules were quite rigid. When you took a dose of NPH, you better plan on eating a meal in 4 or 5 hours, or you're going to be dealing with significant hypoglycemia. So that was a huge challenge for me as a first-year resident because, I might have some 80-hour work weeks early on. And, I'd have days where I would stay up 2 nights in a row. And, having to do that all the time was really difficult. And I'm not sure we appreciated then how we really needed to mold the treatment to the patient because we just didn't have the quality of product to do it. A1C was just starting to be used in the lab. Some labs were still using a measure called glycated hemoglobin, which was a little bit different. And of course, none of the big trials like the DCCT or the EDIC had been published yet. So we didn't even really know if good control made a lot of difference. It was widely speculated that it would. But I was told to try to stay between 70 and 220. Mm-hmm. And that was pretty much my day.
Wow. Yeah, I can. So it's such an odd idea. But so if you took, like you said, you took the insulin, you had to eat within 4 hours. Let's say, did you ever just take it and then eat? Or there was no real consideration for the timing of the insulin, right? Like just that you needed to get this food inside of this 4-hour window?
Yeah, well, you took NPH and regular together. You mixed them. Mm-hmm. And regular peaked about 3 hours later, and then the NPH 4 to 5 hours later. So, the regular was designed to cover the more immediate meal, so I'd like to take it at 6 a.m. and I would have some breakfast. Well, ideally, you would wait 45 minutes before you would eat that meal for the regular to match up. Mm-hmm. But I couldn't do that. So what I did was I would eat a small breakfast and then part of my breakfast again later and then lunch a couple hours after that.
So you were staggering the food to meet up with the insulin.
Yeah, you had to mold your food to your insulin, not the other way around. Okay. And I would just carry a backpack full of stuff. Granola bars, and I pretty much ate that stuff all day long.
And so do you have any feeling for what your blood sugar was doing in those 4 hours? Or do you not? I guess there's no really, it's not like you were testing frequently, right?
No, it was, quite often I did not know. Sometimes I would take a blood sugar at 6 a.m. and maybe not again until 10 o'clock at night.
Right. So
occasionally I would, if I was working overnight on a hospital rotation, like in the ER, I'd have one of the nurses check me if I thought I needed it, whatever that meant. Mm-hmm. But that was not common.
Okay. So you were, if you had to sit here and guess right now, were you probably had an elevated blood sugar most of the time?
I think I did because I probably felt that it was necessary for me to get my work done.
Yeah. Okay.
Because a significant hypoglycemic episode with NPH, with its prolonged peak, could be significant and would last a while.
It just keeps crushing you, and you can't really fight it off. Because at this point, it's possible the food you ate is completely through your system, and now this NPH is still working.
That's right.
Yeah. Okay. And the action time on it was about forever, right?
Yeah. The peak, the so-called peak, it was really more like a dome. Mm-hmm. It was about 4 or 5 hours after you ate, but it really was an hour or maybe 2 hours long.
Wow.
So timing was everything. And of course, given what I was doing at the time, that was extremely difficult.
I think it's good for people to hear that, though, because no matter where you are in the timeline of anything, right? It's easy to be frustrated with what you have because it's not doing everything you need it to do. But the perspective of what you were doing, in the late 80s, the early 90s is, I mean, just it seems almost archaic compared to how things are handled now.
Yes.
When did you make the leap into? Because I'm assuming I'm actually, maybe you're still like, no, I love MPH, but I'm assuming you don't use it anymore. But
no.
What was your first transition away from that? Was it faster acting insulin? Was it a pump? How did you kind of traverse through everything?
Well, it was interesting. I actually started prescribing some pumps while I was in residency. I had really good treatments from my own doctor, but the diabetes community in North Dakota, which was fairly small then, really embraced me. Mm-hmm. And there was a doctor who was older than me who had type 1, and she was very helpful. And there was a pediatric specialist and another adult specialist where I was doing my residency, and they really, really helped me along. They were great. It was so I, right away I started collecting my own patients, some of who I still have now.
Wow.
And I had my first pump patient in 1990. And it was an attorney from Winnipeg, actually. But the technology was not very good then. He was kind of a gadget person. And the first transition away from NPH and regular was when an insulin called Ultralente came out in the mid-90s. And it was an attempt at the first basal insulin, but its quality was still not that good. But it was considered to be a once-a-day then. My experience with it was not very good. And then the analog insulin started coming out in 1999. That would have been like Glargine, and Humalog came along shortly before that. And I'd been using Humalog as an injection. But then in 1999, when the long-acting analogs came out, I'd already gone on a pump by then.
Okay.
So I never used those long-acting analogs.
I see. Do you think that prior to that I mean, you could more than guess at this, but was the treatment for type 1 diabetes prior to that just let's see how long you can stay alive and not die today? Is that it was that was it, right? You were just hoping for the best.
It really was. Some of the early data on control was related to retinopathy. There was a huge Wisconsin data set that had looked at that. And then when the DCCT came out in 1993, that was the big, large-scale, long-term type 1 trial. That this is where we built all of this today, where we think of A1C as a gold standard for most adults, although that's modifiable for lots of patients now. But when that came out, that was huge because we actually knew that control was going to influence a lot of microvascular complications. Yeah. So I started thinking about it differently then, but the quality of the insulins was still not very good. So that was difficult. In fact, in the DCCT, most of the patients were on 3 shots of regular during the day with their meals and NPH at bedtime.
Okay. So you know how when people talk about I'd like to take the New York Giants from 1923 and see if they played the Dodgers from '83 and see like how they would do. I have a question sort of similar to that. If you took a person today who was, I don't know, had type 1 diabetes for 3 years and was just diagnosed 3 years ago, and could put them in a time machine and take them back to you as a doctor when you were 25, do you think that they could kick your butt as far as maintenance of diabetes went?
I think so, because the difference now for patients is not only the quality of insulin and technology, but we have many patients who achieve a very high level of training and knowledge in diabetes. Yeah. Even at diabetes camp, where we have kids, I mean, there's some 12-year-olds at camp whose diabetes knowledge is very high, and that would not have been the case 25 years ago.
Right.
And I think if you have especially very well-trained pumpers who use CGM, their diabetes knowledge is usually very extensive. Mm-hmm. And I think they would have taught me a lot.
Yeah.
For sure.
No, it's just interesting how in the grand scheme of things, it feels like forever, 89 to now, but medically speaking and with advancements, it's a blink of an eye. It's not that long ago.
That's right. I was certainly happy as the technologies got better. That made a huge difference, and I love technology, and I embrace it. And a lot of patients will talk to you about technology. They're sick about talking about diabetes, but they will talk to you about technology all day long. I think that's the difference too.
I think that right now too is the first sort of time in the history of diabetes where new technology didn't mean like, hey, here's this thing, let's hope it works. Now you can actually expect that the next thing that comes out will do better for you.
I would say almost always. I'm the longest running user of a personal CGM in North Dakota.
Okay.
And the first CGMs were just fair. But I would say in the last 3 years, the quality of CGMs is so much better. So, I think that's right. You get to a point where suddenly the product has achieved its quality, and now I think we'll see that just about every step going forward. I don't think there'll be a lot of missteps in the future.
Yeah, it just doesn't seem like that exists anymore. And so are you excited about the idea of putting an artificial pancreas on, or have you had diabetes too long to want to let the control go like that?
Actually I've been on one of them for about 10 days.
So you're up for it then. Okay.
And and it's going good for me. Yeah. Very good. Yeah.
What's the which one are you trying?
I'm using the 670G.
Okay. Is there a user definable target blood sugar, or is it defined by the machine?
No. You actually would do this along with your provider, which is what I did. Mm-hmm. And I have cardiovascular disease, so super tight control is really not ideal for somebody my age with cardiovascular disease, okay. But I run my targets from about 110 to about 190.
Okay.
And, I've had very little significant hypoglycemia on this. Most of my overnights are very, very flat graph. During the day, it's still kind of learning me. Yeah.
Okay. So it's like I was going to say it's like the Nest thermostat. You have to adjust it a bunch of times before it figures you out a little bit.
Yeah, it does. It does have a kind of an artificial intelligence program. And the suggestion is that you wear it for a week before you turn it on to the automated mode. Mm-hmm. But it still spends about another week or two continuing to learn you. And I can see that, actually.
That's fascinating.
And one of our reps here who works for that company has type 1, and she's about 10 days ahead of me. There's 5 of us in North Dakota on this device, and she said it's still doing things that are causing her to think that it's learning her.
Wow. Do you have an example?
Yeah, I do. Just kind of try to follow through with some of the technical part of this. The basal insulin is actually a series of microboluses that may or may not be delivered on a schedule. So if it sees that you're going down, it actually maybe will just suspend that for 10 minutes before it starts delivering again. So it kind of starts to figure out what your response is going to be like to activity, or maybe pushing it a little bit more with a higher carb meal or travel. So there's always something new for it to kind of figure out. You have to still be fairly concise and accurate with your entry of carbs.
Okay.
But even there is some leeway with that, I'm discovering.
Yeah, it's interesting because, the way I handle my daughter at this point is, like carb counting, for example, something that's, I don't think it's classic around here. We don't look at a plate usually and say, I think this is, we don't sit there and count the carbs. I look at that at a meal and I say, you know what? I know this is going to take about this much insulin. And then, and then we're aggressive about that insulin. Maybe mix it with a bolus or a temp basal too, maybe an increased temp basal, and then you kind of live off the Dexcom data here. And if you're seeing a curl up at the end of that line, it's okay. Maybe we missed. If it's a curl down, maybe we missed the other way, and then you can cut back on the basal or add more bolus or whatever it ends up being. We so kind of do that by. It's just how we do it at this point. And so I always wonder, my daughter uses an Omnipod, so we're hanging tight for the Omnipod AP.
It's going to be great too.
Yeah.
So's the T-Slim Dexcom. They're all going to be great.
It's all going to be. It's going to be absolutely amazing. It'll be like kid in a candy store time. But I always wonder, I wonder how the transition will be. like from this to that. But I guess it's just like anything else, right? Like when I went from injections to the pump, it took me a month to figure it out. This is going to take a month to figure out, and then you're just sort of on your way. Yeah.
Well, I think there's first of all, I think there's some merit in the way that you do it, especially if you promote consistency with your method. There's actually a pretty good study in type 2s that show that estimating bolus based on meal size is not a terrible strategy. Mm-hmm. And I think you might know more than you think. It's just not defined by a particular parameter.
I totally believe that.
Yeah, I think that's true.
Yeah, I definitely do because yesterday, every day is a good example with diabetes, but yesterday is a great example that my daughter had dinner, and all of our schedules were staggered oddly. My son came home and he ate, then my daughter ate, then I ate, then my wife came home and brought Chinese food with her. And so my daughter had already eaten, and then I saw her like looking over at my wife's food. She started picking at my wife's food, and we did all this stuff. But I kept my daughter's blood sugar at 96 during that whole time. And it's the bumping and the nudging of the Dexcom line is how I think of it actually.
That's exactly right, Scott. And I think when people have good, well thought out strategies and use the advanced features. Temp basal, dual wave boluses. I mean, however you want to approach that. If you're doing things with the pump that are impossible to do with injections, you can do that kind of stuff. And, I feel like with myself and my patients that their diabetes is successful if their technology connects them with their diabetes, not separates them from it. And what you're doing is you're connecting to it. You have found a system to do that.
Hey, it's December. The holidays are here. How'd you like to get yourself something great? A gift, but it's free. Something to open up your world. And at the same time, release you from the chains of being tied down by a tubed insulin pump. That's right, people. We're talking today about the Omnipod tubeless insulin pump. I'd like you to go to myomnipod.com/juicebox or click on the link in your show notes to try a free, no obligation demo pod today. Listen to what I just said. Free, no obligation demonstration. Sends it right to your house. You take off the boom boom, stick it on. Next thing you know, this is what it's like to wear an Omnipod. You've got the experience. I just recently wore a demo pod for the first time. And I have to tell you, I never even noticed I was wearing it, really. That's the part I like the best. Anyway, at the time of year where we're spending money on other people and putting a lot of effort into other people all the time, which I like, don't get me wrong. Giving, spirit of giving, it's good stuff. Give something to yourself, though. Give yourself that freedom. Give yourself an opportunity to at least learn what it's about. You don't have to absolutely get it. It's no obligation. Let them send it to you. Listen, if you're an adult living with type 1 diabetes, you're an adult, you're probably always thinking about somebody else. Think about yourself for a moment. And you know what? If you're the parent of a child with type 1, let them live an entire life not knowing what it feels like to be tethered down to their insulin pump. You guys, this is a no-brainer, I swear to you. myomnipod.com/juicebox with the links in your show notes. You will be happy you tried it. I think it's the most important aspect of it. I didn't mean to step on you, but it's when the doctor tells you to do something and it feels that uncomfortable, and now this is your whole life, just constantly following this set of rules that makes you, I don't know, uncomfortable, or you're not successful as you want to be, or whatever it ends up being. Then every step of your day, I mean, diabetes is so 24/7 that you're just struggling against against the tide constantly, and I just think.
Well, yeah, it is. I think it. I'm sorry, I didn't mean to interrupt you.
No, please. I was just going to say that I think if you find something that works for you, that's what to do. And I use my daughter's A1C as a mirror to look into and say I think we're doing okay with this. But I think of it's funny, we were in the office a couple weeks ago and her A1C was 5.6.
Yeah,
it hasn't been over 6.2 in like 3.5 years.
Yeah, nothing wrong with that.
It's right, fantastic, right? But then I said to my doctor, I said, hey, I am a little worried about our standard deviation. I'd like it to be lower. Do you have any advice for that? And I watched the doctor sort of change the subject. And I was like, oh, she doesn't have any advice. I was like, wow, that's interesting. Like she can't imagine, what it is to do. Now, in fairness to her, we did just switch. Our practice just did bring in a new doctor. Maybe she wants more time with us, or I don't know what she might want, but it was interesting to think that we had gotten to a point with our care where the doctor sort of sheepishly looked away from me when I said, can you offer me any advice about how to do better? And I think it's possible maybe she can't.
I think the standard deviation is important because it's hard to appreciate this with a kid with diabetes, but as an adult, you have kind of a new set of issues. Most people with diabetes are going to have cardiovascular disease, type 1s or type 2s as adults. Of course, you don't think about that with a 10-year-old kid,
right?
That someday that's where they're going to be. But variability is very important in cardiovascular complications. A1C is super statistically controlled, tied to microvascular complications. And when you get the big printout from your CGM, I think you said you have a Dexcom.
Yeah.
Is that right?
Yep.
I don't even look at the graphs first. I look at the average and the standard deviation.
Right.
That's where the gold is. And, the graphs are helpful. But that average plus or minus is huge. And, 5.6 is great unless you're running, 20% below 40 all the time to achieve it.
Right. And that is something we definitely talk about that here so people understand. Like Arden does not, my daughter Arden does not have any significant lows, on any kind of, it happens once in a while, but it doesn't happen with any regularity. We don't accept.
Well, she's using a pump with a CGM. That's the great thing about these things now at this point in time. Mm-hmm. The rest of it's going to follow, of course.
Yeah.
But
I'm
glad to hear that's her experience.
Oh, thank you. It's a really exciting. I mean, it really is. The possibilities feel very limitless at the moment. And as much as all of this sounds amazing, there's a little part of me that always just hopes for the the quote unquote smart insulin to come, because that really would just. I mean, that would be the end of all this.
Even the ultra rapid acting insulins, which are imminent. Novo Nordisk has an ultra rapid that will be out soon. And what we have really discovered in the last 5 years with pumps and CGM is some of the limitations of rapid acting insulin. It's a quality product, but it doesn't behave exactly the same as native pancreatic insulin. And it busts a lot of myths in a hurry for most people. There's kind of a myth among some type 1s that if they took an injection of rapid acting, their blood sugar was better 20 minutes later. Well, that's not exactly how it works. But the ultra rapids are going to, when you're looking at a sensor profile, it'll be different. Yeah. For certain.
No, I think that, we talk about, I think that a lot of what we accomplish is at its core an understanding of how the insulin reacts in my daughter's body. Like, I think that's, sorry, there's a beeping in the background, but I think that's the core of how it is. Like, when I put in this much insulin and her blood sugar is X, 20 minutes later, you're not lower, you're moving, but if you, but there's times where, like last week was a great example. Like we lost track, sometimes you just lose the handle on it. And she was up at like 2:30 and there's dinner cooking and it's carby stuff. And I don't know another way to put it. Like, I just crushed her with the insulin. Like, I gave her enough insulin for the 2:30 and for the meal, and just made sure to time the food when her blood sugar was, falling quickly at like 140. And when she began to eat, and then we saw it kind of come in for that landing, around 90. But it was, if I didn't understand how the insulin worked in her, then I would have been one of those people going, okay, well, first we'll bolus for this number and then get it down and then the food. And, the whole thing would have taken 4 hours.
It would. And, that's a very good strategy that you have, because you're looking at what's in front of you, but you're thinking about what's going to happen an hour from now.
Yeah, I don't see how to do it another way, honestly. I can't wrap my head around it another way. So
that's a really good way to do that. When the rapid acting insulins came out, like 97, 98, we learned pretty quickly that if we had people thinking about where they were going to be an hour from now, that would actually be better.
Yeah.
They need to assess where they're standing right now, but it's like throwing a football to somebody. If they're running away from you, you don't throw the ball where they're standing. you throw the ball where they're going to be.
That's exactly right.
And people get analogies like that, and that sounds like that's what you did here.
Yeah.
But the other thing too is I deal with a lot of patients who are transitioning into adulthood, and sometimes it's hard for them to understand that what they were doing when they were 13 is not going to work for them now.
Right.
But that's okay. We'll just find another strategy. It's out there. It exists. It's just not what you were doing when you were a kid.
You have to stay so fluid and not get rigid about anything. I mean, I think with the technology or with your day-to-day treatments, like everything, if you get stuck on, well, this is how it is, I mean, your body's constantly changing. It's never always going to be this is how it is. It's just how it is for now. That's
true. I had a stroke 5 years ago, and, it changed my ability to perceive hypoglycemia pretty significantly. And this was about the time that the CGMs were starting to get a little bit better. And that was good timing for me, because if that was 1990 when that happened to me, that would have been really, really difficult.
Yeah. Let me ask you, earlier you said that everyone could expect a vascular issue you meant at some point, right? Like it will come to everybody at some point if you stay alive long enough. Is that
well, it's that minute. It's 2/3 of deaths in adult diabetes, and type 1s have a lot of cardiovascular disease. I think we historically think of it as kind of a type 2 problem, but now we have type 1s living longer than ever. And, they're living long enough to get cardiovascular disease, so their profiles are similar. The difference now is we can manage the other risk factors that adults with diabetes have, like blood pressure and cholesterol.
Okay.
And there's very specific guidelines for that. But it's hard when you're 35 and you've had type 1 for 20 years, and your doctor is talking to you about controlling these adult-type risks, because their focus has always been on A1C and blood sugars, which is still important.
Right.
But I have patients who are living extraordinarily long times. I have one patient in my practice who's 76 who's on a pump. And 25 years ago, that somebody with type 1 to be 76, that would have been almost unheard of.
Well, it's funny because as you're talking, what I realize is the idea that you're going to get cardiovascular disease is sort of good news. It means you're going to live long enough to get cardiovascular disease.
I think that's right.
Yeah.
It is true. Yeah. And the other risk factors are cheap and easy to treat. Mm-hmm. I mean, blood pressure's super easy to treat. And even if you have to take 2 medications, for most people, that's like $12 a month.
Right, and it works. Then that's medication.
And it works.
It's tried and true that works. Well, I have to say, I do like having these conversations sometimes because it is a back of the brain kind of thing for me. I mean, my daughter was diagnosed when she was just a couple weeks after her 2nd birthday. So she's 12 now. She's had it for a decade already, and she's only 12. And so there is that part of you that thinks like, wow, is the bad stuff going to come in her 30s, or is she going to be one of the lucky people who just, it doesn't come for her that early? And it really is. It's nothing you think about day to day because you're living your life. But I mean, it definitely is. It does creep into your thoughts once in a while. I'll say that for sure.
It does. But I think our ability to manage those risks is a lot better. Mm-hmm. 25 years ago, if you were an adult with diabetes and you had high cholesterol, there was very little we could do for you. And although cholesterol is somewhat responsive to intensive lifestyle in adults with diabetes, it doesn't seem to bring their risk down to the same as somebody who doesn't have diabetes.
Yeah.
But we had no way to manage that before. And, now we do. And when you combine that with healthy lifestyle, I have lots of patients in my practice with type 1 in their 50s and 60s who are doing great.
Let me talk today about the Dexcom G5 continuous glucose monitor. Let me just talk to you today about it from my heart. Now, some people are going to think of a CGM as something that alarms and tells you when something's going wrong. And that's not incorrect. If your blood sugar gets dangerously low or begins to get dangerously high, you can absolutely set these parameters so that the system tells you, hey, your blood sugar is below where you want it to be or above where you want it to be, or it's heading in that direction fast. You should know. I like all that. I mean, don't get me wrong. For safety reasons, Dexcom is wonderful. But that's just really the beginning of what a CGM should be doing for you. Get it for the safety, but stay for the amazing ability it brings for you to live healthy. Let me tell you a little bit about that. I'm going to show you something right here on my blog. This is from a year ago, but it's a blog post called Anatomy of a High Carb Breakfast. And in this post, I detail how Arden eats French toast, sliced bananas, green grapes, chocolate milk, bacon, and her blood sugar. I have to look here at it. It never goes over, I don't know, 110 maybe? I did that. I made those adjustments with Arden's Omnipod using the information and the things that I've learned from the Dexcom CGM. Okay? It's that simple. Here, I'll find another one for you. Here's another blog post called You Too Can Bolus for Chinese Takeout. Here's a simple graph on Arden's Dexcom. You go look at it at ardensday.com. But simple graph on Arden's Dexcom that shows that 2.5, maybe 3 hours after Chinese food, Arden's blood sugar was 115. Never went over, maybe, I don't know, 130. Never went over 130. I've spoken past the music. I can't tell you enough that the information that comes out of the Dexcom CGM, not only is it going to keep you safe today, but it is going to teach you how to stay healthy and how to live. Really live with type 1 diabetes in a way that you are not going to feel burdened. Go to dexcom.com/juicebox to find out more. All right, let's get back to Dr. Johnson. And don't forget at the end of the episode, a little teaser about who's on the show next week. I always sort of think that people who have type 1 are almost live a healthier life because you're sort of forced to be aware of your health. It's not something that happens to you. If a doctor doesn't tell you, hey, this is wrong with you, pay attention, then you just go through life thinking like, hey, I'm the lucky one, right? Like every smoker thinks they're the lucky one until the day it hits them, right? You know what I mean? Like it's as long as everything's okay, you have this sort of human belief that it's going to be okay forever and ever. But when someone comes along and says to you, hey, there's an issue, pay attention, I sometimes think that the people I meet with type 1 diabetes are well more tuned into their health than the average population sometimes.
I think particularly the ones who are having some success, that's true. Mm-hmm. I have some people who, they run marathons, and cross-country skiing is huge here.
Yeah.
And, they're out skiing every day in the winter, not complaining about the weather. Those are the ones who are doing well. And, there's plenty of them out there, and you're right. Even if they don't get it when they're in college or some other transition period, if they find it, that's exactly right.
Let me ask you this then. I sort of lost my train of thought. But when you said that there are people who are doing well, like making out well, when people aren't making out well, do you see a commonality in why that is?
Yeah, I think some of it is burnout, which probably sounds obvious and maybe kind of a cliche, but I think we need to understand that there's a little larger percentage of adults with diabetes who have depression or anxiety that may not be, quite as textbook or classic. ADA actually calls it diabetes distress now.
Okay.
And I think focusing more in on those psychosocial factors. When I see patients in my office, I don't look at their data first. I don't even open their electronic medical record. We have a conversation for 2 or 3 minutes about what's up and how things are going. And then we get into all that stuff. So at the beginning, I'm trying to assess that right away with somebody. Like, if they had a change in their life, break up with significant other, change in a job, some other life thing that might be interfering with their diabetes.
Yeah. And
if we can kind of, remember that we need to address that, I think that's really, really helpful. But I do see a lot of depression and anxiety in diabetes. And sometimes if you treat that, the diabetes stuff kind of settles down on its own.
And that anxiety, is that fear of the insulin?
I think it's sometimes really ill-defined, or people who don't trust their insulin or their technology for whatever reason. They seem to have a lot of it because they had one blood sugar of 35, so they think that's how it's going to be all the time. Yeah. Well, that's you might not ever have that, or it might be 2 years before that happens again. But we need to help people manage that and manage their life, and remember that, if we try to put diabetes as part of people's workflow every day, they do better.
Okay. If
it's something that they put in a box on a shelf and look at 2 or 3 times a day, that's not a very good strategy. And the harder they try to separate themselves from it, I think those patients tend to have a lot more anxiety about it.
Well, I think you just said something that I just agree with a ton, which is the idea that you have to trust that the diabetes is going to do what it's going to do. If you start second guessing that, this insulin that I gave is going to do what it's, something different, that'll freeze you. It's almost like it's skydiving. Like, once you got to trust that the chute's packed right and jump out of the plane. And if it's not, then you hit the ground, and that's that. But you can't skydive every day worrying that the chute's not going to open. You have to just believe it's going to. And if it doesn't, then now hopefully you have maybe a CGM or you have something else, and you can help yourself through it. But you can't, I've said this here a billion times, but you can't accept 29 days of an unhealthy blood sugar to guard against the one day this month that your blood sugar is going to get low. You might as well just, you know what I mean? Like, you can't do that. Yeah. That's just giving up, but it taking longer.
And that's courting a whole new set of risk.
Right. Yeah.
Yeah.
No, I think that it's just, one thing we sort of never talk about, or at least I don't even say it enough, I think, is the concept that, you got a lifelong autoimmune disease and it sucks and it's not fair. And, sure, it shouldn't be like this, but it is. And so now left with the factors that exist in your reality, how are you going to make the best of it? I think that if you don't start from there, I can see how it could become oppressive. And it's not beyond me that I found myself just the other day, Eric, I was in my house. I had just done something with my daughter. I went downstairs. It had nothing to do with diabetes. And I found like this sort of quiet moment in my life that I don't see very often. And I realized that the bag of supplies that we took with us this past weekend, she played softball all weekend. So Arden played 6 games of softball in less than 48 hours. So I had a bunch of extra stuff with me, and I had to put it away. And I just looked at the bag and I looked at all the stuff, and I could just feel myself welling up. I wasn't even having any conscious thoughts. You know what I mean? I thought, wow, I'm going to cry. And I stood there for a second. I was like, okay, and then it passed and I put the stuff away. But my personality lends to the pressing on, you know what I mean? But what do you do when you're one of those people who just by the how your brain's wired, something like a moment like that can suck you in and you can't get back out of it again. And then you have diabetes on top of that. And that's just... It
is. And, some of it is mindfulness practice principles. Some of it is, if your life's too busy, we should focus on that. Mm-hmm. We should not, it doesn't have to always be about your diabetes. What can I help you to be a better time manager? I mean, that's how I got to be a doctor, by managing my time. Okay. I couldn't have done it without that. So I need to share skills with them that maybe aren't directly related to diabetes, but might be helpful. And, just trying to get them out of that trap, that negative muck that can be really hard to get out of. And even people who have had a lot of success will sometimes fall into that. And then it's really distressing for them because they haven't seen it or felt that way before.
Yeah. I guess when you're expecting things to go well and then all of a sudden it comes along and kind of hits you in the side of the head, that's probably more distressing than having it have been a struggle the whole time.
Yeah.
And do you have a lot of luck with that with talking to patients about kind of making those leaps? Or is it like when you stop and think about yourself as a physician, if you see 100 patients that are all in a similar situation as far as their mental health goes around diabetes, how many of those people do you pull out to call a success for yourself?
I think if we thought about following them forward through time, some people just take longer to get out of it than others. I would say a huge majority of them would, probably 85 or 90.
Yeah, see, and that's yeah. I'm super glad you said that because something I always sort of preach over and over to people is no matter how bad it seems right now, you won't be here forever.
That's right.
It's just true. If I look back to how I just was speaking with a woman today on the phone, her daughter, her son has been diagnosed for about 2 years. And she's gotten to that great point that everybody gets to where she's starting to realize that there's more to it than what the doctor's saying. She has, a grander desire for what an outcome means daily for her son. But she's stuck between this really interesting place where people get between, well, the doctor told me this, but this seems to make sense. And people have a hard time going against their physician or standing up to them even at some point and saying, hey, I think this, what about this? And what I ended up telling her in the end was, I said, I think the best advice I could possibly give you is you have to trust your gut. You just have to go with what you think is right. And you have to know that this, in my opinion, is just one step that everybody who lives with type 1 diabetes goes through at some point. This will be in your rearview mirror at some point. And she started talking about my daughter's A1C, and I said, no. I said, you have to realize that when my daughter was diagnosed for 2 years, her A1C was in the 8s. You're talking about an A1C in the 6s. Like you're doing way better than I did.
Yeah. Well, it sounds like success for your daughter was playing 6 games of softball in 2 days.
Well, and
that's success.
It was great. She had a great time, Dr. Johnson. There was the night after both nights after both days. Around 1:00, she hit like that. She dropped to 50, and it was that kind of 50 where like, hey, here's carbs, and you're still 50, and so nothing happened, and so I cut her basal off for a while and gave her some food, and it was kind of really cool. She was in the hotel with her friends. They were running around after this day of everything. Her blood sugar was sitting at like 75 before she went to bed, and I was like, you know what? Just go ahead and when people are snacking, just snack right along with them. And so for this like 2-hour period, she just was like having like Girl Scout cookies and handfuls of popcorn and everything. And her blood sugar was just sitting at like 75 or 80. And I kept saying to her, I'm like, either this is going to be like a perfect science experiment, and you're not going to get low tonight. But after what ends up being 6 hours of softball over a 9-hour period, I'm like, you're definitely, it's not going to work. So at around 1:00 when I saw her start dipping down, I cut her basal off and gave her juice, and I was up for a little bit, but it was just, she had such a great time, and so I think you're right. I think living well is, I think they say that's the best revenge, right?
I've heard that before. Yeah.
It really is. Yeah. I think it's just true. I think if your goal's not to live as healthily and well as you can with this, then, what is your goal? So it's
true. I tell people that I'm so glad I got to see this technology, and I tell people who are younger. I don't see patients under 16, but like your daughter or even some of my younger patients, I'll say, I can't even imagine the triumphs you're going to see in your lifetime, long after I'm out of here. But I say things like, it would suck to die 15 minutes before somebody figures this out, right?
And it's going to be somebody's going down, and some guy's walking to the podium to say, "Hey, we fixed the whole thing. Just hold tight 5 more minutes."
Right. Hang on. Yeah. And that's going to be a huge day too. And
sure.
A lot of it is autoimmune diseases are more complex than maybe were originally appreciated. Beta cell transplant is super complex. Beta cells and their interactions with other cells in the body and all the feedback loops and everything. I think that's probably more complicated than maybe was appreciated 25 years ago, but somebody's going to figure it out. And I think the autoimmune disruption is going to have to happen with the beta cell replacement for it to really be a true cure. Those kinds of immune disruptors are used in other autoimmune diseases right now. You see these IV drugs on TV for rheumatoid arthritis. Well, they're immune disruptors, and that's how they work.
Yeah, that's something. It's just crazy to think that encapsulation is something that somebody's working on. Like that. That's such an odd thought. Even going back to, my limited time with it in a decade, it was, I never imagined that 5 years ago when, it's crazy. It really is. And somebody's going to pop through and it's going to be a great thing. And I do always like to say when we're talking about this stuff that, I genuinely think that you should live with all the hope in the world that there's a cure coming, but you can't live every day like you're waiting for it. You have to.
Yeah. You have to do the work, do the job.
Right. In the meantime, do what it is that's available. but I would never lose hope for it. I mean, I really wouldn't.
No.
So.
I think that's true. I'm a member of the American Diabetes Association professional section, and I sit on their primary care advisory group because that's my background. And I go to the big meeting every year, the scientific sessions, and there's 14 to 16,000 providers and scientists there, and it's just so great to just kind of bask in the buzz of thinking that all of these great minds from all over the world are working on this problem or stuff related to it. And, when they presented the 30-year DCCT data, I mean, that was almost emotionally overwhelming. I mean, despite all the limitations of the last 30 years of treatment of type 1, especially the first 10 of that 30, there are still people here 30 years later who've cut their incidence of kidney disease in half. Just by using what was available to them. So, we keep pushing forward. I believe that this is going to happen. I may not see it, but I think there's little question that your daughter won't.
Yeah. No, I have that's my genuine hope, obviously, is that these artificial pancreases are something that even in my daughter's lifetime, we're going to look back and go, wow, I can't believe that's what we were doing.
Yeah, it's a place. They're great, but they're a placeholder.
Right. Now I know
they really are.
Interviewed. I say this sometimes, but his age makes it so valuable. The actor Victor Garber, I interviewed last year, and he had been diagnosed when he was really young, and he's in his 60s now. And he would just talk the way he talked about the things he did, like the boiling, his urine to test his urine, like all that stuff. Even he was like, I can't believe this is what I used to do, and I think that the sign of success is that inside of a lifetime, if you can say that a couple of times, I think that's how you're going to be able to tell we're moving forward quickly, and not just
that's true. Yeah. I have a vintage 1930s injection kit. It's a steel needle that you have to file. The syringe is glass. I had a patient who I took care of until he was 68 when he passed a couple of years ago, and he said, if he broke his syringe, he might not get one for a few days. I mean, it was glass. It was glass, and they had to, and he would have had to go to 150 miles to Fargo to get it.
There was someone on the podcast who told me that her mother broke hers, and they had to work out a payment plan with the pharmacy to get them another one, because it was so even incredibly expensive back then. She couldn't afford it.
Yeah,
it's fascinating.
It really is. Yeah.
So, I don't know how much of this you're comfortable talking about, but when did you notice your cardiovascular issues, and what kind of an impact have they had on you?
Well, I had another significant risk factor with this. I had been smoking starting when I was 15 until I was 40. Mm-hmm. And, it's one of those things you wake up one day and you're going, why am I still doing this? And at that point in my life, my busyness was really controlling me. And although I felt fairly successful with my diabetes, not all of this life management stuff was really coming easy to me, for whatever reason. And I had a stroke that affected my vision when I was 44 in 2004. And that was a huge wake-up call. And at that time, everybody was... They were focused more on some of my other risk factors that maybe weren't as well controlled, like blood pressure. And so we really got a lot more aggressive with that. I kept having I had a few TIAs, and then I had another stroke event in 2012 where I developed some left-sided weakness. And I think what happened then was they were really confused because my risk factors were pretty well controlled, other than just the fact that I had diabetes. I mean, and you can't always control family history. I have a pretty strong family history of cardiovascular disease on my mother's side, and you can't control that genetic part of it as well. But I actually ended up having a kind of unusual heart rhythm problem that was predisposing me to stroke that didn't really get solved until about 2014, 2015. And then with the right medications, now that has just all stopped.
So had that been discovered earlier, the strokes may not have occurred?
Or with the frequency. Yeah, certainly. So I think there were some other factors, and I think that's an important lesson too. We can't always blame the diabetes for everything.
Yeah, right.
Sure, that increased my risk, but that wasn't the entire story here.
Right. You were still smoking and
yeah. And that was I should have been done smoking in 1989. Yeah. But I just there's no other way to say it. It was I just didn't. I was too busy with my life to always do the right thing. And looking back at it now, it seems perfectly ridiculous, and it sounds perfectly ridiculous, but I don't mind sharing that part of my story with people because I want them to know that I didn't always do everything right, or I would be so focused on one thing to the exclusion of everything else that I thought I was doing everything right.
Well, to this point is just going on in my own life right now. I've an older son who doesn't have diabetes. He's 17. My wife is, in her early 40s. The two of them got sick a couple weeks ago. It started off with a little bit of pressure in their head, and then suddenly they were coughing, and now it's been 2 weeks, and they've all been to the doctor. They're taking medications, and it's oppressive. They're still not
right.
well. They're run down. They're tired. They don't remember the last time they felt well. They don't remember the last time, and there's this sort of. I think I came to realize about a week into it that my job in all this is just sort of like cheerlead them through. Like, hey, it's, how's it going? Are you feeling better? I bet you. My son will come home and be like, I don't think I'm any better. I'm like, I bet you are, and like, you just,
right.
Because
That's
of how
cool.
easy it could be to just sort of, because he's still going to school. He's keeping his grades up. My wife's still going to work. We're all still living our lives, but it's a snapshot for me about, when I hear people say, oh, it's too much. I have this diabetes and it's just every day and it's constant. It's too much.
Yeah.
My son's cold's going to go away at some point. But, what do you do? What do you do when your diabetes isn't? And do you think that, so were you smoking, first of all, it was the time, right? Like smoking wasn't thought of as poorly when you started, when you were a kid, I'm imagining.
Oh, no. I started smoking in 1974 and, we didn't have the knowledge that we had now. And, when I talked earlier about, there's some people who they just have this busy factor in their lives where they're just not they're not creating space to have success,
right.
with diabetes or, anything else that's going on with them, even outside of that. And I was really kind of in a place like that. And, but, certainly by 2000 when I quit, I knew.
Yeah.
I knew what the issues were with that. But, I like to share with my patients that, I haven't always done everything right, but here's what I can teach you about this. Mm-hmm. And I think that's great. I think people really like that.
Yeah, I've been meaning to tell people, so we're kind of wrapping up here at the hour, so I'll say it here. But I know when people hear, I share my daughter's A1C so that people can think, wow, I bet you I could get to that too. Because I was as big of a mess handling diabetes as anybody was. And if I can get here, then certainly you can. But at the same time, you have to recognize that sometimes people see those numbers and they go, oh my God, I'm never going to get to that. And, or, what perfection that must look like on a CGM graph to get a 5.6 A1C, but that's not the truth. The truth, if someone's sitting around imagining that my daughter's blood sugar is just 85 all day long,
that would be wrong.
Yeah, that's not right. And so, even in the midst of a good day, and I would say that when she was playing softball the other day, I was kind of kicking butt on Saturday. I mean, she was between, I think 70 and maybe bounced to 140 maybe once or twice, but then there was a spot in there where I don't know what happened. Like I missed, and she jumped up to 180. And I know for most people, they're probably like 180. Shut up, but
yeah.
But Dr. Johnson, for me, 180 is well outside of what we're shooting for. Like it's no different than saying to a person who's like, I'm willing to accept 200, saying they went to 300. If I go to 180, I'm well outside of my acceptance range. And so she had this spike. I got it back again. And then, like I said, she had the low overnight that we had to deal with. And it's not like, there's no autopilot. That's for certain. But at the same time, I hope that people understand that you can be very far from perfect and still be doing a really great job.
I think that's true. Yeah. I think you have to, just kind of be sure that you're celebrating your successes and not being overly focused on when something doesn't go exactly right.
I just,
and we do planning for people. We say, well, you know what, you're getting married in a week. Here's what I would do.
Mm-hmm.
I would not make diabetes number one on your list, but let's have some prevention strategies so you can really enjoy your day.
Yeah.
Or you're going to go on vacation you're going to go to Europe. Well, maybe tight control is not our objective, but let's keep you safe while you're on this trip.
Right.
And when things are going well, ride it. That's a streak. You don't mess with a streak.
Exactly.
You don't just go with it.
Well, I don't even think of when it goes wrong as a mistake. Like, I try very hard when things don't go the way I expect. I just try to think of that as data telling me how to do better the next time. Like that to me, it's not I did something here. I don't usually record this late in the day, but so this is over top of my daughter's softball practice after school. And so I let her stay a little higher about an hour ago than I normally would have, because I just, what's the reason? You and I are doing this, and I can let 25 points go for an hour, and it's not the worst thing in the world. Her A1C will still be well under 6 when we get it checked in 3 months.
You bet.
But we're still gonna, you and I are gonna finish up here in a minute, and I'm gonna get a hold of her and tell her to bolus, and be on our way. And that's back to come full circle. It's the genuine gift of the technology that my daughter can look at a 140 blood sugar and say, I can adjust this without a finger stick and without having to pull a needle out and stick myself with it. I can.
Yeah, isn't that great?
Yeah,
and
amazing.
I think kids who learn responsibility through their diabetes end up having very good life management skills later. They're able to handle other responsibilities.
I see that so far with her. I mean, she's just she's well more mature than she probably should be, but not in a way that makes you sad for her. You know what I mean? Not like she's a 50-year-old lady walking around in a 12-year-old's body. Just she has a way of considering things that's advanced. I guess is the only way to say it. So.
It's just different.
Yeah,
and
it's her.
I've seen that. I did diabetes camp for many years, and I saw that in these kids. The kids who really were responsible about this, they were responsible about everything. It was incredible, really.
Yeah,
I learned a lot from them.
Well, you know what? And that's a great message, I think, sort of to kind of head out on, is that there's always going to be somebody doing something with diabetes that, I think that's why this podcast is I think that's why people like it. I think it's you sit and listen and you hear somebody else tell their story, and then you sort of either find yourself in it or you find motivation in it, you know what I mean? And then maybe you reach a little further because you say, hey, this person did it, or maybe somebody tells a story and you're like, wow, that happened exactly to me. And that makes you feel a little more normal, and that's a lot of, that's a big weight off your shoulders too, just not feeling alone. So.
Yeah, I think that's exactly right, Scott.
Well, Dr. Johnson, thank you so much for coming on and doing this. I really genuinely appreciate it.
Yeah, I've enjoyed our conversation very much, Scott. I hope we can talk again sometime.
Oh, that'd be wonderful. Thank you to Dexcom and Omnipod for sponsoring the podcast. Please go to myomnipod.com/juicebox or click on the link in your show notes, or dexcom.com/juicebox, or again, click the link in your show notes. Hey, don't forget, if you need a Bold with Insulin t-shirt before the holiday, it is time to order now. And by that, I mean this is like the beginning of December 2017. If you're listening to this like 3 years from now, I don't even know if the shirts are still for sale. I might have sold them all by then. Just go to juiceboxpodcast.com to see the styles and sizes that are available. And now your brief audio tease for next week.
Strikes out 3 batters. He's been doing that all postseason long. What a pitcher.